Jaguar, because anybody that owns a Jaguar knows you have to buy 2 Jaguars, one to drive when the other one's in the garage. I think it's a very poor example.
Okay.
And none of those are made in America.
Okay. But you know, I have my eye. Okay, I'm sorry. I'm gonna find something better than the Jaguar. You know, I have my eye on the fact that we spend more than any other developed country, and that if we don't do something to be sure that we get the right care in the right place at the right price, we will have fewer and fewer people who can afford health insurance. Thank you.
So we'll take some questions, and please let us know what your name is and who would you like to ask.
I'd like to ask a question for Dr. My name is Patricia Dean. Doctor, 2 questions. I understand there's a debate about Jaguars and all that. I also understand how nice it is to walk into a place like First Choice, but we've all got to be concerned about the cost of medical care in this country. How do we access First Choice's numbers for either Colorado Springs or Arvada, preferably both, or preferably all First Choices across the United States, to compare what are service charges versus facility fees? Where do we get that information?
Yeah, I'd have to defer that because I'm not part of that decision process.
Is that transparent? Can we go online and look at that?
No, that information is not. It's not transparent.
And why
because
not?
Again, well, because it's a competitive marketplace, and we bill competitively, like the hospitals do. And I think to the point regarding insurance, we'd love to be in network, and getting in network with an insurer is all about negotiation. So it's not like we dictate to them, you're going to pay this facility fee at this number. They come back, you negotiate, you go back and forth. So
can you give us an idea of what your fee for service or your service charges are as a ratio to your facility fees?
I don't know. I honestly don't know the answer to that question, but I will say that the information that was up on the screen regarding the facility charges versus the professional fee, which is what I'm assuming, comes from an unknown insurer, and it could be a hospital-based freestanding ER. We don't know.
That's part of the problem.
Yeah.
If we can't get it from you, how do we get it?
Well, why can't we give them the same price that it takes for that same 300 people? What would have it cost if they had gone to Lutheran versus here?
That question was asked at the state capitol to Blue Cross Blue Shield Anthem, and they refused to answer that question because they said it was, quote, proprietary information. So it's the information that the insurance companies hold. It's contractual from hospital to hospital to provider to provider.
And you would allow for any insurers to provide that information if we push them for that information? Or does First Choice have, I think for all of us to be good consumers, we have to have an idea of, is your business model work because of the facility fees, or does it work because of the care you're providing? Simple.
Free market.
Right. It's with regard to the insurer, releasing that information. Right now, we don't have a contract with Anthem. I would love to have one. I know we would love to have a contract with Anthem, and hopefully we can negotiate one at some point. But again, as far as giving out proprietary, I actually agree with Anthem that when you start revealing all your pricing information that makes you competitive in the marketplace, you have a choice. You don't have to come to us. You can go to Lutheran, and it's. I'm sorry.
To answer your question, is it because of models, because of money, or is it because of great care, Press Ganey scores?
Yeah, so Press Ganey, which is basically what is it?
The J.D. Powers.
It's like the J.D. Powers. It does a patient satisfaction survey every year. They're like the J.D. Powers. We, First Choice, and obviously not so much exactly the Colorado experience because we haven't been here that long, but from Texas, came in the top 95%, in fact the top 1% for patient satisfaction. I don't know how those numbers could exist if we weren't billing appropriately.
Let me just ask one thing. Can we ask you how many patients you saw how many patients you see per year? I know the Arvada Center hasn't been open very long, but how many patients you've seen per year in Colorado Springs?
I honestly don't. I don't have that information.
And they just met their 1-year mark as well. I don't know the numbers for Colorado Springs. I don't work down there, but
to the point that the volume to the point that the volume is less. Yeah, that's true. But as to a total number, we don't.
Would you be willing to give us what you pay your emergency room docs versus what they pay at hospital? None of them. Okay.
I can tell you it's less.
Lorraine.
Okay, this question is for the senator. Obviously, we have a systemic problem within our healthcare system in the whole United States. It is not just Colorado. And oh, by the way, I was treated at Denver General Hospital back before anybody was probably born in the summer. But my question is this. Knowing that we have that systemic problem, why are we suddenly picking on a new model that has come out when quite obviously this problem has grown through the years? And, you know, I ran my own business. I wouldn't share my numbers in a public meeting like this. I don't think that's fair and it's not right. But I want to know why now we are going after a new model as the problem that's been systemic for many years.
So I do want to let you know, I am not only going after this new model. This is one of 6 bills that I'm running, right? And in addition to this, I'm doing that bill about the administrative costs. I'm creating a commission to look at everything. But the reason I picked this, I can tell you in one picture. It's this. So this was Houston in 2004. This was Houston in 2014.
What's that got to do with us? You didn't say anything about them. You said you didn't know anything about them.
No. So what's bad about this is, let's assume that in each of these, a private insurer is paying $2 million in facility fees. All right? So there's $8 million in facility fees in 2004. This is 2014. How many millions of dollars in facility fees is that now?
What was the population growth in that decade?
Yeah, a lot.
Houston.
A lot.
$2 million in facility fees, but otherwise we pay to a hospital.
That was one.
These are private ERs here, or our public ERs here. I grew up in Houston.
Well, yeah.
And those
No,
are,
I just meant those.
right, because I mean, how many
Right.
of these are actually private
So,
versus public?
but she asked me why did I pick this? Because it's new, right? And if somebody wanted to say, just grandfather the two that are here, I'd be willing to discuss that, okay? But what I've been told is that Health One has 2 planned, Centura has 2 planned, First Choice has 4 more planned. This year, property bought. So we're gonna go from having whatever number we have now, 4 or 6, to having 14. And each one of those, from each insurer, because remember that was one insurer who I gave you the statistics on, is going to cost us that many millions of dollars to support the infrastructure. Now, do we need access to emergency care? Yes. Do we need access to emergency care every 2 miles so that we don't have to wait 10 minutes? Well, if it's a real emergency, you won't be waiting. You get put to the front of the line. If it's not a real emergency, then you can wait 10 minutes. That's what I'm talking about. So it's because it's new, and because we have the opportunity to stop it now before we get to here. And I'm hoping with my cost commission that they find out what they can do so that every single one of these are urgent care, primary care, and are open. So I don't mind the thought of all those facilities being there taking care of people. I just don't want them getting a bonus to help them have their door open, because we all pay for that. All of us who have private insurance. The public insurance does not pay for it.
Kelly?
Yeah, I have just have a continued question on this. So I appreciate what you're saying about that particular one provider's cost for the 1 year for Colorado Springs.
For one insurer.
For one insurer, right. So that's a single example. My question is, I look at this and I wonder, would the citizens of Houston and have the insurance companies in Houston said, this is terrible? Or have they said it's actually improved healthcare? What do the citizens and the insurance companies and the doctors in Houston say about this?
So I can tell you the emergency room doctors are concerned about provider shortages and about true level 1 trauma centers not having enough. Right. Because all of these are staffed 24/7 by emergency room doctors. There are only so many emergency room doctors, right? So we have provider shortages already in our state. You start opening up a lot more facilities that need emergency room doctors. Who's going to work at a place where you see 100 people an hour versus 100 people
So
a
is there
day?
data on that? I mean, do you have actual data
Well,
showing
actually,
that there's actually...
it's funny that you should ask, because I'm working with Dean Matthews at CU Law School. They have just started a health law policy department, and I have 2 law students right now who are looking at utilization data in Colorado, and then around, and in Houston, and what's happened over the time period. So hopefully we'll have data soon.
So I would think that would be critical before we
Yeah.
make
That
any
would be,
decisions.
what she said she does.
So,
Christine,
Senator
yeah.
Aguilar, a couple of questions for you. Are you saying that it's bad to have all of these centers in Houston because there's not enough doctors to staff them? Or wouldn't the better solution be, let's see if we can recruit more doctors? What level of care are Houston citizens getting in these centers? If it's a recruitment problem, let's solve the recruitment problem. Let's not shut down the centers so that they have access to fewer options.
So I
That's
would.
one question, and then I have a couple
Okay,
more.
go ahead. Oh, do you want to say?
Go
Okay.
ahead.
So I would agree with you that we obviously need, doctors have lived a life of cushdom where they've been able to set their hours and make people come to them when they want to be seen, right? And the hours are not set around when a patient wants to be seen, they're set around when the doctor wants to work. And so we do need to solve the problem of access to care, as any of you who've had to take off work for half a day to see a specialist know. We need to have hours available when they're convenient for the working man, not for the doctor alone, right? So I would say that likely they need more doctors in Houston. My question, based on that slide I showed you about the Mayo Clinic versus UCLA, is do they need more emergency rooms in Houston? So I do think they need more access to care. They may need more access to urgent care, but do they need the level of care that you have to spend to sustain to have it be emergency rooms? Because what we're talking about is sustaining a building 24/7 with full-time staff and equipment and supplies, right? And so, and ultimately, all we pay for this is our $150 and our premium. And what the impact of this is going to be is on our premium. I don't know what the impact, like you said, has been directly in Texas. I can tell you they have the highest number of uninsured people in the country.
So,
Yeah, please.
Can I quickly respond to one thing too, with regard to access to care, and I think the assumption is that it's not a problem. The American College of Emergency Physicians actually gave the nation a grade of D- in terms of access to care for emergency services. Colorado actually got a slight upgrade last year, and again, this is just hospital-based emergency care. They got a D+. I still, if your kid came home with a D+ on his report card, I don't think you'd say that's a passing grade. So what we're doing, what we did in Arvada, and what we did in Colorado Springs, is we gave you another option, another point of access to emergency services, which the American College of Emergency Physicians clearly says we need.
And what I can tell you is that actually, even if you go to a hospital-based ER, I don't know what the exact number is, but at least 30% of people there don't need to be there either. They could be seen in urgent care or in a doctor's office. And so I think this is not as much an access to emergency care issue as an access to care issue. And what I would like to see us do is provide more urgent care and primary care and use that $2 million per facility to pay the urgent care centers and primary care centers more so that they're open there for you when you need them.
Christine, give a follow-up.
So the other thing I was hoping you could help me understand is this whole term, access to care. You started out at the beginning of your presentation saying that certain people don't have access to care. And I think if I kind of understood where you were going with your point, that it's not that these people are not, do not have the physical ability to go into a center and access whatever care they need. I think what you were really intending to say is the health care that is accessible to them is expensive.
So two things. One is, you're right. I mean, at the end of the day, everyone can show up at an emergency room.
And
But what
everyone
used
can
to,
call the doctor and make an appointment to go see them for an ear infection, right? It's simply a matter of, is my
Convenience.
insurance gonna pay it, is Medicaid gonna pay it, or am I gonna pay it out of my pocket?
right.
Okay,
So,
and there are people that could choose to pay less for other things in their family budget so that they could afford to pay more for health care. Is that true?
that is true.
Okay.
Right. But what I'm also saying is that if you have insurance, you just pay your copayment. There is no incentive for you to find out what it really
Okay,
costs.
I don't pay a copayment, I have a high deductible
Okay.
plan. So when me and my family go to access our health care, which we do have accessible to us, we write a check. We write
Yeah.
a very big check.
Yeah, And so, and then with regard to the access issue, there are actually some people who can't find providers who will take them. Medicare and Medicaid, for example, can't find providers who will accept their insurance. And then if you don't have insurance and you don't live in Denver County, there's not providers who will take you. University actually is not a state facility. They don't take the uninsured. So there are people who truly have no access. And then there are people who wait in line for access. And if you have cash up front, you probably don't have to wait in a line. And so, and if what you said to me was that First Choice would only see people who will pay them cash up front out of pocket, I wouldn't care. That would be great. Leave them there.
Laura.
But how do you regulate that and have them labeled emergency? You know, it's hard to do.
Senator Aguilar, can
Yes,
you go
ma'am.
back to the screen that's titled Cost of Insurance? This one.
Oh.
There at the bottom, I think it's very telling that there's not the data from Lutheran or Denver General that says what their facility fees are. And I think there's a gross problem in letting the government say one facility can charge a fee and another can't. It's messing with the whole free market system. And I really have a problem with you trampling on rights that way.
That's right.
So what I would say to you is two things. One is that Denver Health and Lutheran have a hospital available to you 24 hours a day,
And
7
isn't
days
that
a
your
week.
goal, just to shove all the emergency business to your hospital systems instead of to the private businesses?
So
That is
I
your
think
goal.
if you have a life-threatening emergency, you need to be at a hospital. Because there are no life-threatening emergencies that can be fixed and
So
discharged
the answer to that
within
would be
6
yes.
hours. Yes.
What about?
Okay,
I
not
would
being
say-
political, it's
No.
yes or no.
I think if you have a life-threatening emergency, you're gonna be at a hospital at some point in that emergency, yes. I think that if you, that you can't compare sustaining a freestanding building to sustaining a hospital.
I think as citizens, we're so tired of big government. We're so tired of government reaching into our lives and telling us everything we can do, from the light bulbs we use to the size of Cokes we can drink.
Yep.
This is about making government bigger. It's not about limiting government.
Yeah.
This is actually limiting the government, because Medicaid and Medicare are gonna be the same. This is gonna affect your insurance premium, not Medicaid and Medicare.
Marianne.
As a nurse and former hospital administrator, mother of an ER nurse, and married to a physician, I would say it's time to listen to the IOM and their quality improvement, which has looked for creative ways to provide health care. It would appear to me with the facts and figures that the people of Houston have spoken to say that they want a choice. I would also, having been involved with it, was question on the data. And I think you need data on recidivism, and the return of how many times, they're coming back to the hospital with the care. A standalone building doesn't mean they don't have the equipment. I used to run an ER, and we could take care of things in an ER without having to worry. In fact, the trauma surgeons and the surgeons came down to our ER. And I think another thing to look at with data is, which is not here, is when we compare the 15,000 with the 60,000, there is no indication that of the side effects of falls, of drug errors, or any other issues that cause to be coming back. I will say right now, as a Medicare person, and I wish I wasn't, I look at right now, they're telling me that I can't get the same knee replacement I used to like it with private insurance. So what they're doing is reducing the quality of care for patients. And if we have one choice, we have reduction in quality of care. For those that don't know it too, the Canadian system actually has two systems. You have your government system, but those that can afford to pay are able to get in faster and able to do care faster. So,
And we actually have 4 systems here. We have people with good private insurance, 5. People who can pay out of pocket, the sheiks who fly over here. People with good private insurance. People with Medicare. People with Medicaid. And people who have nothing.
the people that have nothing are often taken care of in the hospital system. I did not know very many that came in and paid $150 because our billing department, I always got involved with different things. They negotiated payment. I don't know anybody that was doing $150,000. If they declared bankruptcy, then they would have help with things like this. But the middle class needs to have a choice, and so the rest need to have access to care. And if we destroy it down to one approach, we're losing that freedom of choice. I would say the hospitals have a recruitment problem, but a few years ago, they did with physical therapists, also with nurses, and they did something about it.
Diane?
I don't know if you can hear me or not. You know, having been to the ER 5 or 6 times with my 88-year-old mother, and then, you know, a hip fracture, and then a son with playing baseball and the sports, we've been to several ERs. I outright will say quality care, I would not, I mean, I have no doubts in my mind. I mean, when my son went to Vista, it was smaller, we walked right in. You know, at Lutheran, even with their senior ERs, I mean, they've tried to accommodate for populations, there's still problems with that. The point I'm making is, how you evaluate that quality for the cost, I think is very, very difficult. And on the cost basis, it's really hard. I sort of can't imagine coming into some place without having contracts with major providers, okay? Meaning the negotiation involved with lowering fees kind of thing. You know, even though you're private, you know, profit kind of thing, I just find that interesting that you can do that when so much of the whole, because of people, population, like say Anthem or United, just 2 of them, and then Kaiser, you know, there's a lot of people involved, so there is more negotiating power, and obviously being able to reduce the power on something like that. Okay, so, and it may have been done, but when you mention not having but wanting, and
right, with Anthem. We do take insurance, and you are covered for, we have a multi-plan agreement, which basically is employers who have, you know, a lot of different insurance companies will buy this provider group, which includes us. So
right.
it is
and
a
I just
lot of
don't
major.
know what percentage, like take
Yeah.
Colorado. You know, how many people are Kaiser, how many people are on Anthem, and when you were asking on some of those with all those ERs, I would love to see the information of cost with all of those from some of the bigger providers. You know, and I don't know what they use as a quality base, but there's a lot of information there versus what may be happening in Colorado. So, you know, that kind of thing I think is interesting. The whole cost thing, I find very interesting because until I started asking for the bills, now does that sound strange? How many of you know, I had a fractured hip a couple months ago. I was absolutely horrified. You know, 2 days in, $75,000, not including any of the surgeon's fees, any of that. So I started saying, I want what you sent to Medicare. I want what you sent to these people. And I went through it and was horrified. Okay? Do I have any choice in that? No. I mean, but we don't know. You know, when you talk about choices of people, you don't know. And even people are starting to say, how when I go in, you know, they compare like colonoscopies. You all know that within a period of time, you know, a location, the rates, okay, are very, very different. So there's now supposed to be certain numbers so you can get sort of a ballpark. I think we have to move. I know you don't need, you know, you shouldn't have to disclose certain things or maybe with businesses, but with choice, you gotta have some information, you know what I mean? What it is and what you're getting for your money. And you can't do that. It's not like going to the grocery store when you end up and have an emergency. So, you know, that kind of thing to me, you know, I mean, that's realistic. But I do think that until we see things and you get your statements or ask for your statement, we're not going to be aware, okay, of some of these things that are taking place. And I think people, you know, just need to start asking that and be more aware of it too.
But there is a difference between getting a bill for something I did and knowing what the costs are that I'm being billed for versus asking a business to give up all of their aggregate data and their profit data and all that.
Right, you're talking about more facility kind of charge. But you get a good idea though of some very detailed, like, I couldn't believe the hardware alone in my hip. My gosh, I mean, it was like, anyway, I won't even touch you, you know. So you do get a good idea of what was substantially paid for.
Where did you go? Was that a hospital or was that? Yeah, so I mean, and I feel like there's some of that happening, like when they put up some of the cost data, say picking on, you know, what the term is, freestanding emergency centers charge this and showing the facility fees. Those numbers are meant to shock. You see those and you go, wow, clearly the facility fee is out of control. How's the battery holding up? I'm looking at being given a very partial story, right? So what is involved in the facility fee? Why is that? Why does the hospital get that? Why are we not taking on the hospital? Why are we not talking about doing away with the facility fee for everybody?
Everybody,
Right?
that's right.
So
Yeah.
those things aren't being discussed, so I just feel like I'm getting a little bit of a shell game. And I don't know that that's.
Well, and that was why I showed you Panorama and Golden,
Which
because
is
they
the
get
other
no
shell game.
facility fees.
Totally. So we have time for one more question. We'll let Blaine ask it, and then I do apologize, but we have to give it the room. The city manager was good enough to give us the room for an hour and a half, and
Thank you.
then we have to go. So.
My question is this, I'm just going back to a point in your presentation, you were talking about where you'd like to go, and we're talking about a cooperative that everyone pays into, based on income and so forth, and I'm thinking it through, and maybe I'm missing something, but it sounds to me like a variation on a single payer system. I'm wondering if you could explain if that's where you'd like to go, or am I missing something?
So, one of the, and I hate to say single payer because that word means so many things to so many people.
I'm
So,
just talking about it in
yeah.
terms of taking the
Yeah.
choice
So what-
away from the individual and giving it to the.
No, what I'd like to do is that everybody pays for their insurance premium based on a certain percentage of their income, and the numbers we had modeled were I think it was a 6% employer payroll, 3% individual payroll. And then you go on to something like the exchange, and you pick the providers you want to see. And then the providers compete against each other for your business. And the ones, hopefully, who do the best job get the most patients, and other models dwindle and new models come up. And so that's what I want. So I absolutely don't want a government-run health system. I can tell you that legislators don't know anything about health. You want doctors and providers determining what's covered in healthcare. But I want us to save the 30% or the 27% that we waste trying to figure out who has to pay what bill and negotiating those 50,000 different prices, to instead be, you compete for my business because you give me the best care, not because my insurance company got the best deal with you. Most of you, if you look at who you get to see with your insurance company, that network is getting smaller and smaller. Because what's happening is insurance companies are now only letting you see people who give them a good rate. And so I've had a number of constituents complain to me that they can't go to University Hospital anymore because their insurance company wasn't able to give a good rate. So the current insurance system does not give you choices. In a cooperative, everyone would take you.
Long discussion, but I'll leave. Thank you very much.
I do have a little 2-page handout on my cooperative idea, if you want to pick one up.
I want to thank the senator for coming. And,
Thank you.
Dr. Collins, everybody for being here. Like I say, we have to clear out of the room because there's another group using it after us. But thank you so much for coming, and hopefully we'll see you all soon.